insurance. And I think I sit here privileged to, and I see a lot of my colleagues, I think I'll appreciate them. Everyone who is a caregiver in the insurance, most of us have a background of, personally I'm a nurse. I see Dr. Mureithi from KPLC, I see most of my colleagues are in the house. So Dr. what I would want also to say is, the people who implement insurance, we are not just payers. We are not just the financial bit. So we sit in between the care and the finances. So what happens? There are policies. I started by saying people sit on a round table, just like paying dowry. Negotiations happen. But you see, while you're implementing the care, you know the last bit of what the insurance is giving. But I would assure you a lot goes behind the scenes in terms of negotiating for that client to have that benefit. So apart from saying that, is we have also evolved, and I started by saying that before we never used to cover. Right now, I can tell you mental illness or mental disorders are covered just like the way you would cover diabetes, hypertension, and true to my word, you can do your research. Also depends with which partners have you partnered with. Are they still living in the old insurance ways? Because the ones who have evolved are actually giving. The only thing we would not sit here and probably say it's happening is what maybe the doctor would expect, pay everything. Because even when negotiations were done, there were rules and policies put down regarding that particular cover, and we call them sublimits. But when you get to hospital, for instance, I've said about diabetes, cancer, you might even need okay, maybe I'm in that category who doesn't know the difference between clinical but I know the clinical one who goes to see people who have other comorbidities, right? So we will pay everything for as long as a mental profession is needed for your care, we cover. At that point, there are no sublimits. Matters suicide. We say now people who die by suicide. We have covers like last expense. In insurance, when someone dies, we don't even check what you've died, the reason. If it's a last expense cover, it is covered. Right now, we put it, and I would dare most people to check the current insurance policies, because even that is covered. We have covers of alcoholism. I just said, I don't know, maybe you're not here. Even rehab, we are paying. When I worked in Jubilee Insurance 15 years ago, I remember my first daughter, who is 12. Maternity was never covered. I was told that is not an illness, and I had to pay. But what happens? Maternity is covered nowadays. So, Dr. I would want to probably engage with you and any other spaces where the clinical team that sits in between care and insurance, so that we can work with you to understand how the policies, on the other side works. Thank you. Thank you, Dr.
Thank you so much. Thank you, Rosemary. Thank you so much, Evelyn, Benjamin, Leah, as well as John. Asanteni sana. In the interest of time, let's put a pause, because our panelists are still here and the conversation does not end here on this stage, okay? So if you have more questions, they're still here until the end of the day, I hope. So yeah, you can mingle with them during lunchtime and ask all your questions. But for now, allow us to say thank you. Thank you for, listening with us. Give them a big round of applause. And even as we make way for our group CEO to address us and the keynote speakers, I'll ask our panelists to just stand here for a very quick photo session as Dan takes over.
Thank you very much to our panelists. It feels like we need to just have a whole conference on parenting and another one on police. Venye kunaka, yes, guys, don't go home with those wounds. You've been told there is a screaming booth downstairs. And then, in addition, on and off, we'll be putting up a QR code for you to scan, and you're going to get, by virtue of you being here, you're going to get a free subscription of the Nation for a week. So we'll be putting it up. And then also, when you go on your Play Store and App Store, there is NTV app, NTV Mfukoni. Do a point of downloading it. You get all our amazing content over there, even what you don't see on TV. So, without much further ado, I'd like to invite Mr. Geoffrey Odundo, the Chief Executive Officer and Managing Director of the Nation Media Group, to come and address us. Karibu sana.
Good afternoon. I must say that sitting there and just listening to the panel has been quite interesting. This is one space that I think we've never paid attention to, but I think, actually I've never visited a psychologist. I think we should, and I'm stressed. I'm really stressed. Probably I need to do that so as to build a bit of quality life, as Benjamin had said it. Benjamin, we're guilty as charged. We spend too much time out there. We probably need to think about how to change some ways. Thank you very much. I want to appreciate everybody for making time to be here and over lunch, which is quite unusual. But just to say that thank you very much for making time. This is a very important area of discussion. I think with the increased cases of mental health issues we're seeing today, even in today's paper and all these kind of things, I think it's a very topical issue for the country, and we need to take it quite at another level. So we're very happy to be promoting this as Nation Media, and happy that you've all turned out and we have a full room here. I've really enjoyed the conversations coming through and listening to each panelist, including the police force. I didn't know I can actually just call in and say hi. I'll purpose, but in case I'm caught, I'll call you. Okay. So I want to just recognize our chief guest. I think she's not here, but the PS, oh, she didn't make it, huh? The PS State Department of Public Service and Human Capital. She was our key guest today, Jane Imbunya. Our keynote speaker, Dr. Catherine Mutisia, consultant psychiatrist, now we know. Qureshi Abdullahi, Executive Director, Institute of Human Resources. Prof, thank you very much for your elaboration. Our esteemed speakers who I think have started and continue for the rest of the day. Our partners, ladies and gentlemen, good afternoon again. So it gives me great pleasure to welcome you to the 4th edition of the Mental Wellness and Counseling Conference, a great conference put together by my commercial team led by Mr. James Ogoti. James Ogoti, well done for keeping this going. We are honored to be hosting this event in partnership with the Institute of Human Resources Management and the Kenyan Counseling and Psychological Association, which are two institutions that have stood at the forefront of championing mental health awareness and professional counseling in Kenya. Ladies and gentlemen, as we gather here today, we are reminded that mental health is no longer a peripheral conversation. It is central to the national development, to organizational performance, and to the individual well-being of every Kenyan. This year's conference continues a journey we began 3 years ago, a journey that's grounded on evidence, shared experiences, and common vision, which really is that building a mentally healthier Kenya is so important, and it helps build a more resilient Kenya. So everything that we do, every conference we hold is evidence-based, because we do a lot of research on sectors, on themes, on what goes on, and then we try to bring out a conversation to see how we can address those issues. So we just don't do random conferences, we do evidence-based conferences. Indeed, we are living in a time where global conversation around mental health are growing louder, and rightly so. Improving the quality of mental health services requires a multifaceted approach, one that looks beyond just treatment. We must focus on early intervention, widening access, implementing evidence-based practices, and creating systems that are equitable, inclusive, and sustainable. Ladies and gentlemen, back in 2023, the Ministry of Health launched the National Guidelines on Workplace Mental Wellness, a key milestone that signaled a turning point in Kenya's approach to mental health. These policies reflect growing recognition that mental wellness is deeply intertwined with our national productivity, with sustainable economic development, and with our ability to live in dignity and thrive. We must also acknowledge some sobering facts, which is that according to the World Health Organization, 1 in every 4 patients seeking primary health care in Kenya suffers from some form of mental illness. Within our Kenyan workforce alone, it is estimated that 3.7 million Kenyans out of the 24.9 active workers grapple with mental health conditions, including anxiety, depression, substance use disorder, and bipolar mood disorder. These are not just statistics. These are our colleagues, our friends, our family members, and sometimes ourselves. That is why, as a nation media group, we have chosen to leverage our convening power to create a platform for dialogue and serve as a catalyst for meaningful action. I must confess that we all have this in our families. I mean, I have a sister who went through a depression many, many years ago, and just getting her out of that situation was not easy. So I'd like just to help, to just wish everybody that these are really our family. We need to stand with them. Don't think it's, anybody suffering from a stressful issue is something that can be managed. I think we just have to be together in such situations. Create safe spaces for them. The theme of this year's conference is improving the quality of mental health services in Kenya. Therefore, it gives us an opportunity to explore strategies to enhance access, equity, effectiveness of mental health care through evidence-based practices, policy reform, and collaborative stakeholder engagement. From this conference, we aim to share global best practices that are not only evidence-based, but are culturally appropriate. Mental health care is not one size fits all. What works in one context may not translate effectively to another. We also seek to promote prevention and early interventions in workplaces. We recognize that timely support can significantly reduce the long-term impact of mental health challenges, especially in high-pressure work environments. By fostering early awareness and equipping employers and employees with the tools to identify warning signs, we can create healthier and more resilient workplaces. In the case of the nation media, or the media, for instance, we have witnessed journalists covering conflicts, refugee crisis, climate, natural disasters, violence, abuse, and deeply emotional human stories. Sometimes they experience anxiety, depression, lack of sleep, and eating disorders, as well as burnout, trauma, and post-traumatic stress disorder. So this is actually very close to us. And this realization led us to ramp up our efforts to provide professional mental health support services for our staff, especially around traumatic events. While some of these conditions are triggered by traumatic experiences, others are situational or genetic. Our role as employers then is to ensure that we are creating awareness, avenues for open communication, and providing professional support. As I conclude, ladies and gentlemen, it's my hope that by the end of this conference, we will generate solutions and ideas that strengthen our national mental health system. From policy development to capacity building, funding, coordinated efforts are needed among government agencies, the private sector, civil society, and mental health professionals. Together, we must advocate for reforms that make mental health care accessible, affordable, and fully integrated in our public health and workplace policies. As a media house, we'll continue using our platforms not only to raise awareness, but to influence decisions and advocate broader support for mental health care. So really want to say that we will continue to support this key discussion, which I think is quite helpful. And I think it's more important. You know, I've just come from an event in the US around the United Nations conference. And on the sideline of that event, we had a we had a health diagnostic discussion. And the whole process, the whole issue is about how do we encourage people to go for diagnosis through checkups and all these kind of things. So I think in your basket of your health checkups, it's important that we now include psychology, just as a checkup. Not that you're facing any issue, but I think that having that discussion is regular with somebody who is professional in that space is so important, especially for the youth. I think the generation we are dealing with today has very high expectations, want to quickly achieve success, want different working lives, want different spaces. And these are the people we need to mentor in a special way. So asanteni sana, please, and don't forget to buy the Business Daily, which is our flagship product around this area, and there are 3 copies on the table. It's available digitally, and it's going to be available even in better ways going forward. So thank you for coming. Happy to engage with you, and I wish you all a great day and a great afternoon. And yes, let's support this sector, which I think is so important for our country. Asanteni sana.
Thank you very much, Mr. Odundo. And I'll just let you know that I have seen a counselor. I have seen a counselor, I go for therapy fairly frequently, so you can join the team. No, you don't stress me so much, so very much. So, but it's important, guys. I'm a huge champion for therapy and mental health, so do it. It's not about the extremes that we've often heard about. I'd like to invite for a keynote address Dr. Catherine Siango Mutisia. She's a consultant psychiatrist, as she had said, and she's going to give us more insights regarding the quality of mental services, I should say, in Kenya, where we stand compared to the world. Karibu sana, Daktari. And after her, we can go and have lunch, so don't worry. Feed your mind, then your body. Let's encourage her with a hand clap. And remember, even when you go for lunch later on, make sure you pass by the different displays of the different organizations so you can be able to get the value they are offering.
Thank you very much. It's good to know that you go for therapy. Unfortunately, there is no one who would admit that they see a psychiatrist. Even those who have. Good afternoon, everyone. I think we should stand and stretch because it is said that sitting kills more than smoking and what else? So let's stretch. Am I allowed to move the crowd? So some of us might have had a Sunday school rhyme of, I will make you fishers of men. So I want to jog your mind to prevent dementia. So I would want, whenever you hear a W and an F, as a woman you sit. If you hear a name for men, you sit, and vice versa. So I'll demonstrate. I will make you fishers of men. So men, M, make, M, F is women. So women can multitask. So you look out for F and W. Can we do it? I will make you fishers of men, fishers of... Hey, some men are just standing. That's cheating. That's cheating. I can spot one. So can I do it without being part of it? And I see who is not sure. Not that there is anything wrong with not being sure, because we recognize that we have the third gender. So I will not, I just want to see your concentration. So if you don't move at all, I'll assume that you are the people who don't want us to remove the gender bit, right? Not that there's anything wrong as a psychiatrist. So I will make you fishers of men, fishers of men, fisher. Hey, Tobias. So thank you very much. So my name is Dr. Catherine Siango Mutisia. Sorry, I started with a controversy. I want to recognize the Nation Media Group. Interesting, in 2010, I was among the top 40 under 40. Again, in the Business Daily. And in 2014, I was also in top 40 under 40. And it's a challenge to the Nation Media Group. Where is top 50 under 60? When is it coming? What is going to happen to us? So, with all due respect to the CEO and the MD, Nation Media Group, Mr. Odindo, who has delivered a very good speech, the chair of KCPA, Professor Catherine Gashuda, who is also my friend, all professionals and colleagues, and people with lived experiences. Good afternoon. So I'm supposed to give a talk on the quality of mental health services in Kenya as compared to other countries. And before I do that, I would like to share my experience practically about the mental health team. So, in the private facility where I work, can we see the psychologists who are represented today from Nairobi Mental Health Services and Nairobi Parenting Clinic? Are they there? You could stand, we see. Please clap for them. Please stand. How many are they? We have 3 in-house today. You can see a gentleman. You know, there are very few male psychologists. And the men here, sometimes they want to cry with a man. So at Nairobi Mental Health Services, Nairobi Parenting Clinic, we also have male psychologists, and we have all ages of female psychologists. We also have psychiatric nurses. Shomith, can you look behind? Shomith is our BSN nurse who has also specialized in psychiatric nurses. We also have other cadre administrative staff. Jennifer is behind there, is one of our administrative staff. And to crown it all, we have 5 interns, and we have 1 PhD on practicum. We have 1 master's on practicum. We have 2 bachelors on practicum, and we have 1 diploma on practicum. So we are all rounded. We work with occupational therapists. We work with physiotherapists. We have social workers. So the mental health team has to be complete. We can't separate the two. And there are incidences where somebody might come to me and I send them back to the psychologist, or they require both of us. There are many cases my psychologists are here. You can talk to them over lunch. They would come to them, but they still say, where we have reached, you still have to see the doctor. Psychiatrists are medical doctors, so you have to become a doctor first, then specialize in psychiatry. So back to our topic today, the quality of mental health services in Kenya, where we stand compared to the rest of the world. Let me brag that I have been the chair of the African division of the Royal College of Psychiatrists. I attend the Royal College of Psychiatrists every year, and so I am sharing international experience as well as local experience. I've headed Mathare National Teaching and Development Hospital, the clinical services, so I have seen it all. And in Mathare Hospital, I must say, we have over 20 psychologists, we have over 20 psychiatrists, we have over 200 psychiatric nurses, over 20 social workers, occupational therapists, and physiotherapists. So we value teamwork. No one can say they'll do it alone. So where are we as Kenya? We know globally, depression, anxiety, substance use, they make up a large proportion of global disease burden. And as per WHO, the number of years lived with disability in mental health disorders, especially depression, anxiety, is quite high. And we are now seeing disability committee for the nation. We are also recognizing disabilities related to mental health conditions. So the main challenge is, we know that many people globally have no adequate access to treatment. And we also know that the high-income countries tend to have more of psychiatrists, psychologists, counselors, psychiatric nurses, and they spend more than those of us who are in low, middle income countries. What about access? Access to healthcare. We were talking about the earlier session. Access is far much different in the urban centers compared to the rural setup. And we know that for us to deliver mental services to the country, it has to start from primary prevention. You have seen me in media houses talking basic mental health promotion, basic mental health promotion. I've seen psychologists doing the same. I've seen nurses doing the same. I've seen general doctors doing the same. So we have to start from the primary healthcare detection. How do we detect? How do we refer? What is secondary treatment? What is specialized treatment? We can always refer up and down. It is not cast on stone. And we have to align that with SHA, because SHA has packages for preventing and promotion and services for treatment. Now, when it comes to barriers, there's stigma. I have told you today, I know, I can give for a fact, someone here has seen a psychiatrist, but they will not say so because of stigma. By the way, I'm in the panel for National Media Group is covered by Jubilee, right? I'm in that panel. And we will come to the discussion we had with my friend. You know, now I have the mic. That yes, insurances will cover mental services, but they'll cover with a cap. So somebody is insured for 3 million, but mental health is 200,000 only. Why is that so? Even for services where they say, because I know places like Kenya Airways, they have negotiated a package with Jubilee for rehabilitation. The cap is so small. When you suffer from other diseases, you can use up to 5 million. But when it comes to psychiatry, rehab, it is 100,000, top it up. So that is discrimination. Yes, they are offering it. When it comes to outpatients, if you look at the empaneled psychologist, Professor Catherine, you need to look into that. There are very few empaneled psychologists. And they will tend to go for the counselors. Not that there's anything wrong with counselors, but we all have different levels. So they need to onboard everyone. And the reason why they would go for basic counselors at certificate level is because of the cost. So that is not right, because we want Kenyans to enjoy higher standards of healthcare. So when it comes to access, we've talked about access at different levels. Barriers in terms of stigma, cost. How much does it cost? In Mathari Hospital, you have to pay 500 shillings to have a psychotherapy session. If you are going to take bus fare, let's say from Mathari North, or from, let's say from where, which is the farthest part of Nairobi. Let's not even go to Machakos County, because the river is Machakos. Let's not go to Kajiado, because Rongai is Kajiado. Let's say somebody coming from Embakasi, going to Mathari Hospital. At least now we have Mama Lucy offering psychiatric services. We have Bagadi offering psychiatric services. But many Kenyans don't know that. So we need to be able to reduce crowding in the Mathari Hospital and have people back into the counties. Cost, even in government hospitals, is very expensive. Even in KNH. Anyone works in Kenyatta National Hospital here? I know consultation is not less than 400 shillings. So, access, and when you tell that person who is not working, lives in the slums, is paid 200 per day to come and pay 400 shillings, pay bus fare, and buy lunch. Are they going to afford it? Cost, lack of awareness, policy shortfalls, and are some of the common barriers. What about legislation? In Kenya, we are doing very well, but are we enforcing rights of persons with mental illnesses? Non-criminalization of suicide is a good plus, but like I challenged, it is still not all done. The penal code has not been changed. Are there lawyers in the house? By show of hands? Yes. Has the penal code been changed to align with the ruling? Okay. Okay. So when are the other laws which feed into that going to be changed? Yes, so there's a big gap. We celebrated, but there's a big gap yet. We are yet to do that. So we are doing well with, what about integration of mental health into other services? So we talk of maternal deaths, mother-child. Those of us who are mothers, if a mother is depressed, will they take their child for immunization? So what will happen to that child? they'll die because they were not immunized for TB, they were not immunized for hepatitis. So you cannot separate the two. If a mother has postpartum depression, do you know in Mathari Hospital, we have mothers through the court system who have killed their own babies because they had delusions? Are we saying a mother like that, who has delusions, who thinks the baby is deformed or it's a ghost and they are killing the baby, that mother does not need medication? Will that mother listen to therapy alone? No. There's a role for everything. Come to Mathari Hospital. How many of you have been to Mathari Hospital? Ah, good. We have a forensic section and a civil section. What has led people to the criminal side of the hospital? Those are people like me who got sick, but they could not, you and me, they could not access treatment. So a mother got postpartum depression, and those who are able to access care, accessed care. Those who are in the village, they come from all over, northeastern, from western, very far parts of the country where they think it's witchcraft. And before they know it, that mother has killed the child. A man has killed the father. A brother has killed a brother. So these are real life issues that need treatment. So what about the prevalence? We know that 40% of people sitting in accident and emergency anywhere in Kenya have a mental health condition and they may not know. There's something we call hapa na hapa syndrome. Do psychologists know that? Leo naumwa na hapa, kesho ni hapa. We call it hapa na hapa syndrome. That is somatization. So somebody will come to you as a doctor, general doctor, naumwa na mgongo, naumwa na hapa. You do all the tests and you can't find a positive one. What does that mean? That this person is not able to communicate their emotional problems in any other way other than physical. When I say I have a headache, you will leave me alone. When I say I am feeling sad, it is stigmatized. So we have to understand the context. And that's how come 40% of people attending outpatient clinics are not even diagnosed. I had said that 50% of mental illness is diagnosed before age 14. And 75% by age 25. For those of us who have gone through University of Nairobi, or most of the universities, University of Nairobi had sick bay. Many people broke down in their university level and got severe illnesses called schizophrenia. And many of them will know of Dr. Owiti and Dr. Kigamwa, because those are the doctors who serve the sick bay. How many people went through University of Nairobi? So I am sure you know there's a sick bay. And we know, the reason why I'm saying some of these severe illnesses can be diagnosed very early is because university students are in their 20s, early 20s. And we have seen many of them being diagnosed then. Then we lose a lot of money, over 50 billion per year, due to mental health conditions, absenteeism. Kuweka koti and you're not performing. So we lose a lot of money. And so we need to invest. For every cost, for every shilling put towards mental health care, prevention, promotion, we save a lot of money. What about the strengths? We are able to recognize the burden. If you look at our media houses, I think Nation Media Group, all the other media groups are competing with you. Citizen is talking about mental health. KTN is talking about mental health. I think they are being challenged by this conference. So if you look, you'll see everybody today has just decided to talk about mental health, which is a good thing for us, isn't it? Yes. So, where were we? Infrastructure. We've talked about the costs, and we are just like other low and middle income countries. We can recognize there's some data, but we are still not there. Because if I cannot record suicidal attempts in my private practice, how will we ever capture suicidal attempts? Is there a way? I know there are some researchers here. How many professors do we have here other than Professor Catherine? Tuko na professor wangapi? Daktari wangapi? PhDs, hakuna? Oh, kuna PhDs. Thank you very much. So those of you who do research, there's a gentleman there. If we don't, as a doctor, the patients I see, I do not record that they are a suicidal attempt. because the insurance will not pay. How will you ever give me correct data on suicidal attempt? Please stand and answer. Oh.
Thank you for the question. So usually, sometimes when we do file reviews in the facilities, we look for information in regard to the diagnosis, and the diagnosis can give us trends that will then inform health policy. So if the insurance companies make the practitioners not record the correct diagnosis, then we are not able to have a national outlook in terms of the suicidal trends.
Okay. What about, this one I will not ask, but maybe I can ask my psychologist, because we work with them. How many of our patients come and say, you cannot give me a sick-off written consultant psychiatrist or Nairobi Mental Health Services? Faith, have you seen any? And I have to borrow a sick-off from my neighbor who is a gynecologist or from my neighbor who is a surgeon. And this is real to them. They cannot have a sick-off written mental health services. They cannot have a sick-off written consultant psychiatrist. I also do a clinic at Nairobi Hospital, Anderson Clinic, every Thursday. The reason why I've continued doing that clinic is because there are patients who say, I would rather go to a general hospital. If you come to Nairobi Hospital, Anderson Clinic, on a Thursday afternoon, I will treat you. I'm a consultant psychiatrist. But your sick-off will be written Nairobi Hospital. And there is no place for consultant psychiatrist. It will be a medical practitioner. So what does that tell you? We are yet to deal with stigma. Then, weaknesses under diagnosis. There's a lot of underdiagnosis. Very low numbers of specialists. Like the psychiatrists are few, the psychologists are few, and even they are not absorbed. Professor Catherine and your team, you need to fight to have more psychologists employed by the Ministry of Health, because we have gaps. Makueni County is doing very well, so you need to quote it as one of the examples of those who have taken many psychologists. And the worst of all is that we are all concentrated in the cities, Nairobi, Mombasa. Many of the mental health specialists are in the urban areas. Integrating mental health services, KNH used to say, Kenyatta National Hospitals, if it's a psychiatric patient, take them to Mathare. A mother has delivered and you're transferring them to Mathare. We thought that they have a mental health unit. Now they have a mental health unit. How do you separate the body and the physical? And the mind. Sometimes you need to integrate both. Psychiatric units, you know, they are short, they are few. Referral system is weak. Legislation and policy and funding, we know there's a lot of underfunding. There is a very small percentage given by the Ministry of Health towards mental health, and we know that. I know Nation Media has all those facts, so I let them put them in their headlines so that I don't spoil their headlines. There is need of recognition of the need to decentralize the policies. You know what the counties say. The national government cannot dictate to them what to do. So they decide what to do. They decide whether they are going to employ psychologists, whether they are going to employ psychiatrists, whether they are going to employ social workers. So we need to see how policy can be enforced in the counties. There's also funding gap, which I've said, implementation of policies, stigma and access barriers, I've already pointed to that. Costs are prohibitive. I've mentioned even government hospitals. 500 shillings, go to a therapist. The very serious therapist will charge you 8,000 per session. Personally, I've paid 8,000 per session. How many Kenyans can afford that? I have also accessed therapy. So those of us, the MD has gone, please tell him not to be scared to access therapy. So there are psychologists who charge 8,000 per session. Wako hapa? Are there some here? What is the average? Prof, how much do you charge? How much do you charge?
The psychologists charge at different levels.
Yes.
Between 3,000 to 10,000.
Yes.
Depending on the client.
So even 8,000, clientele or your experience. You can't say because I am a doctor, you will charge me more than Mama Boga. I think you should say according to your expertise. Because there are some therapies which are very, all those factors. Oh, depending also on where you come from and what you do. Okay, and whether it's insurance. By the way, it's only, the insurer, my friend from insurance is still here. Oh, you're here. It is only the international insurances which can refund 8,000 for therapy. Am I wrong? The others will not pay more than 3, will not pay more than 4. Ama yenu inalipa ngapi? Now, this negotiated rate, you sit down with an HR, some companies have interest, kuna kengine mnakata, they agree on a funny deal, the poor worker is not there. Am I not talking about the reality?
Dr. Oiti, 4,000. Then there's a Dr. X, 8,000. I will ask my team, my client, to go to the people I've negotiated with. I have contract with Oasis, I have contract with Chiromo. So what I'm saying is they negotiated, because we also not only negotiate with you as an expertise, which we respect, but based on volumes. Remember, we are giving you many other clients, not you as Catherine. So are we able to negotiate?
Fair enough, and I agree with you. I am in most of those insurances panel, and I have negotiated with them. But if I am charging 4,000, and I have a cover of 100, divide, consultation peke yake, 100,000 divided by 4, medication tuseme inakuja 10,000, let's say average 15,000 for every visit, medication, therapy, and psychiatrist fee, 15,000. How much will 100,000 take me, outpatient cover? Chukua calculator.
You know why I don't want to go to that, Daktari?
Yes.
Because in insurance, again, when you look at that, with that angle, I look at a mother who has also a maternity cover. They go in, they complicate, they have PPH. Like, medicine is very broad. So we are not able to probably fit in that based on what I had originally said.
Thank you very much.
Yeah.
Many people in rural areas do not have physical access to treatment. We've already said that. And affordability stigma, we've already discussed that. Sorry, I keep moving my cursor. We've talked about scarcity of data. Let's now compare how Kenya fares off. Kenya is worse off than the Western world in terms of specialist to patient ratios. You can Google that and see. Availability in rural and primary care settings. I've said most of us in urban centers. Funding. We don't fund mental health well. Service utilization compared to many countries that have invested heavily in both middle income and high income. So service utilization, you know, when you're utilizing services, you could have a very nice clinic there. But if I don't know that I should go there, I have many patients who come to us, and my psychologist here can attest. A whole year, somebody with schizophrenia, amesomewa Quran a whole year. Now, this is delusions, hallucinations, amesomewa Quran for a whole year without accessing treatment. That person has hospitals surrounding them. But because of their faith, they prefer, some are beaten, some are nachomwa. There are many others who will be prayed for. They move from one pastor to another. I am not saying prayers are bad. I'm Christian. But let's do them together. Let's have that assessment. So we've said the service underutilization, and the key areas of concern in Kenya is human resource shortage, primary care integration, where you separate mother-child funding. Of course, funding is a main gap. Stigma and legal barriers, legal frameworks being implemented, like what I've just said, the example I've just given. Access and equity. Affordability is a barrier. Monitoring data and quality assurance. Now, I hear my concern of the nursing officer from Daystar. Am I right? You are a nursing officer. And we work very well with nursing officers. And you cannot do without a nurse. Even our our CEO of SHA alituambia hivyo. Unaona hawa ndio wana run hospitals. So, what was I saying? That there is limited data on outcome, system performance, follow-up, interventions, and integration. Even for us to know that we should work together, we need a whole CME to understand how we can work together smoothly. But however, in Kenya, we have recent improvements and positive signs. The legal process is improving. We can quote the decriminalization of suicide. Policies, we've done many policies. I was key in launching the mental health policy. We have launched many other, the act, it came into effect. The mental health task force, we went to all the countries, all the counties. The opportunity to be in the secretariat, we went and we did a very good report. I hope you have it. Look for my picture, you'll see me there. Anyway, so the policies, I said, yes, we have policy at the national level. Does the county listen? How do we make our counties listen? And so that we can have decentralization and integration in the primary health care. Studies and mapping. How do we make sure that we allow, by removing stigma, so that we can record properly? How Kenya could improve to meet higher global standards? We need to move more in line with better performing countries. Consider scaling up training of all cadres. Let's not fight each other, but fight for increase of the training of more cadres. All of them are needed. Let's fight for increase in budget allocation, specifically for mental health. Let's fight for strengthening monitoring and data systems. Track access, outcomes, and service quality. How do we track? I've remembered why I remembered my friend here, nursing officer from Riara University, that when it comes to tracking and quality service delivery, we know there are quirks. And I agree with you, there are doctors who do wrong things, just like there are nurses who do wrong things. And there are also psychologists who do wrong things. So the key is making sure that people do the right thing. There are guidelines, there are councils. There's a nursing council which manages nurses. There's a KMPDC which manages doctors. Matilda is here, the CEO for the psychologist. Is she here? She. Okay, who is representing Matilda? Thank you. Okay, so the council for managing psychologists, you need to manage and make sure people are doing the right thing. So I agree with you. When there's no monitoring and there's no check mechanisms, then we have good people doing bad things, and they are all over. And it cuts across, including with our MPs. It cuts across. But then there are some good people. So welcome to Nairobi Mental Health Services. We have some Nairobi Parenting Clinic. We have some good people. So we will not treat you, will not give you medication if you don't need them. And we will also not deny you medicine if you need them. We also need to leverage on technology. We need to conduct public awareness. Please, whenever you're called, there are people who say, how much are you paying me? Please do it for the sake of mental health. Just go and give that talk, even if you're not paid. In summary, because I know I'm standing between you and lunch, and you are very annoyed with me, because you want to go and eat your lunch. In summary, Kenya has many of the formal pieces in place. So all is not lost. The law, the infrastructure, and some specialized capacity. That's why we have a room full of psychologists. So it means we are somewhere. But in practical terms, for many Kenyans, mental health is difficult to access. And I've already elaborated that. It is costly. And in some places, it's non-existent. Compared with higher income countries, Kenya is far behind in workforce density, outcome tracking, and that's why my colleague here is concerned, because some people do the wrong things. prevention and primary care. Many times people associate doctors, I'm a doctor and I'm a psychiatrist, with just a prescription. That is wrong. You have to talk to me, let me know why you have diagnosed me, what are my choices. I can choose not to take medication. Even if my mental capacity is okay, I can still make that decision. Just the same way, a patient has a right to refuse surgery. Even if I tell you, if we don't do this surgery, you're going to have this complication, you have a right to say no, as long as your mental capacity is okay. So people need to recognize that. Compared with high-income countries, Kenya is far behind in workforce. I've already said outcome tracking, prevention, and primary care coverage. Compared with peers, by the way, we are better than some countries. I am teaching DESTA class, psychopathology. So me, I am a friend of psychologists and I'm a psychiatrist. And I'm also a friend of nurses because we have employed many nurses at Nairobi Mental Services and we have employed many psychologists in the Nairobi Mental Services. So I'm a friend of all those cadres. So I am teaching a class of psychopathology at DESTA University. And one of the students there, from one of the Eastern Africa countries, I won't mention which one, I asked them, did you attend the webinar, the free webinar I sent you in the morning to listen? Because that webinar was talking about management of insomnia for both the psychotherapy and the medical bit. And he asked me, what is a webinar? And I'm like, after COVID, there are some countries which do not know what a webinar is. So Kenya, we are far ahead. Then I asked him, because he has a legal background, in Kenya, courts have moved to online. Does it mean in your country you don't go to court online? And he tells me we are just trying it. So you can see we are ahead. We are doing very well. We can do online sessions. We can go to court online. So in East Africa, we are doing very well. No wonder Tanzanians fear us. So we are doing very well. And the Congolese come to live here. I hope there is none of them here. So we are somewhere in the middle. Of course, South Africa is ahead of us. So better than countries with very minimal mental health services, we have countries like Sierra Leone. We train their psychiatrists. They have 2 psychiatrists in our whole country. And they have no psychologists. And they have a teaching university. They teach medical students. So you can see where we are. But we are still below the best practice. And that's why you can have some of us concerned. If I go to a psychiatrist, they'll give me medications which I don't need. Because some people are not following best practices. We need to make mental health a priority. There is no health without mental health. Thank you very much.
Thank you very much, Doc. And thank you all for paying attention. I do know at this point, whatever I say, I might say the most life-changing thing right now. Asa, what was, mnasikia dan ama mnasikia njaa? So I have a feeling what I'm about to say is relevant to that njaa. Should I say it or not? So lunch will be served at Acacia Restaurant on the 3rd floor. Okay. As you exit the room, you pick your meal cards, your meal vouchers at the exit doors. So make sure you pick those, otherwise utaskia aibu. All right, so thank you very much. 14:36 hours. I request that, I know you're hungry so you can eat quickly. That's a good thing. At least we're not in a nutrition conference. They'd probably tell us the disadvantage of eating quickly. So let's kindly meet here at 3:20 sharp. 3:20, kindly. That you can pick up from there. So your lunch is blessed. Thank you.
Halima not only does the intricate Arabic, Indian, Moroccan design,